Welcome everyone to today's webinar, Patient Collections, the growing focus on technology, consumer protection, and best practices, sponsored by National Medical Billing Services. I'm Emma Goodman with Becker's Healthcare. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it's now my pleasure to start today's webinar by introducing our presenter. Kylie Kaiser is the Vice President of Clinical and Regulatory Affairs for National Medical Billing Services. Kylie has been a registered nurse for over 13 years with experience in intensive care nursing and outpatient surgery. She holds a Master of Science in Nursing, Leadership, and Health Systems Management degree from Drexel University. Over the past several years, Kylie has served as Executive Director of multiple ambulatory surgery centers, using her unique clinical background and understanding of operations to drive quality in patient care and organizational development and growth. She is passionate about the cultivation of high-performing teams and invests extensive time in coaching and mentoring both healthcare and business professionals. Kylie has specialized in several areas during her career, resulting in certifications in ambulatory surgery center administration, medical practice operations, and healthcare risk management. She is a certified Lean Six Sigma Black Belt focused on operational efficiency and practice improvement. Kylie serves as National Medical's Compliance Officer and remains active in Washington, D.C., visiting Capitol Hill and meeting with lawmakers to further healthcare reform efforts. Her distinctive experience in healthcare services and business operations allows Kylie to provide National Medical's clients with supportive collaboration as they effectively operate their facilities through an ever-changing healthcare climate. Kylie, it's now my pleasure to turn the floor over to you to begin today's webinar.
Well, thank you so much, Emma, and thank you to everyone at Becker's for having me here today, and good afternoon to you all. I'm so pleased to be able to speak with you today to discuss patient collections and its relationship to the patient experience. We'll discuss the use of technology, growing trends in consumer protections, and identify some best practices to help you maximize your revenue. Today, we're going to walk through a brief review of the past and present relationship between the healthcare provider, consumer, and payer. I'll also address reasons why patient collections, primarily at time of service, are so important, exploring things like growing consumer protections and collection practices. And we'll discuss how new technologies and automations can help you to not only improve efficiency, but also maximize revenue. We will begin with a quick look back at how providers made money in the past and compare that to what things look like today. In its simplest form, getting paid for services has historically gone something like this. Most Americans had some form of health insurance where they paid a small co-payment at time of service, and then the insurance company would pick up the remaining bill in some form or fashion. Now, while that is still the basic framework for how things work today, we know that a great deal more goes into it. Previously, both private health insurers and federal payers, like your Medicare and your Medicaid, operated under a fee-for-service system. Under fee-for-service, the insurance company pays for whatever the physician, hospital, or other healthcare provider charges once they submit an insurance claim. In the traditional fee-for-service reimbursement model, healthcare providers were paid for the amount of services that they performed. The costs were determined by looking at what commercial payers would pay in the private market and a percentage of what Medicare would have paid for similar services. Rates for services were also unbundled, meaning each service was paid for separately. Unfortunately, under fee-for-service models, cost variations for procedures and tests increased, and the healthcare industry ended up spending more to treat patients, even though patient outcomes were not necessarily improving. As healthcare costs continued rising in the U.S., the government responded with value-based care models. These reimbursement and care models focused on advancing quality of care while increasing patient access and accounting for price at the point of care. Value-based reimbursements are calculated by using numerous measures of quality and determining the overall health of populations. Unlike the traditional model, value-based care is driven by data where providers must report to payers on specific metrics and demonstrate improvement. Under these models, providers are incentivized to use evidence-based medicine, engage patients, upgrade health IT, and use data analytics in order to get paid for their services. When patients receive more coordinated, appropriate, and efficient care, the providers are rewarded. One could easily argue that although this is a step in the right direction, focusing on the patient outcomes, it has also complicated the process for providers. To participate in value-based care, CMS developed several models for providers, such as accountable care organizations, bundled payments, and patient-centered medical homes. And at this point, nearly 50% of payments have been transitioned to this model. Of course, over the past few years, CMS has rolled out MACRA and the MIPS APM models. The merit-based incentive payment programs and advanced alternative payment models expand the requirements for proving quality of care and improved patient outcome in order to get paid. MIPS and APM models were first applied to eligible clinicians, including physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists only. That means that although these models do not directly apply to the ASC facility, many of the clinicians that we work with are impacted, and administrators may end up acting in a supportive capacity to those eligible clinicians in their ASC space. As the program matures, CMS intends to expand eligibility requirements to encompass more providers, which they've presented in this year's physician fee schedule proposal, adding physical therapists, occupational therapists, and others to the eligible provider list. The APM model, while it is available to most eligible clinicians, it's less widely used at this time because it typically requires significantly higher financial risk for the providers. You do, however, have the ability to gain a greater positive adjustment in payments if you are successful under this model. Eventually, CMS aims to tie all Medicare payments to value-based care models. At this point, almost all health plans or hospitals are using some combination of value-based and fee-for-service reimbursement models, with bundled payments being the most rapidly growing form, making up nearly 20% of all reimbursements over the next 5 years. Bundled payments are not new. They've existed in the hospital market for many years. However, they're now expanding and continuing to expand to procedures performed in the outpatient setting in an effort to support cost containment. When we think about the patient experience, it is very easy to understand how bundled payments can benefit patients. With this model, patients end up receiving only one bill for services instead of individual bills for pro, ASC, anesthesia, lab, and others. And this allows them to more easily manage their medical expenses. Now that we've set the stage for how insurance reimbursements have changed over the years, let's take a look at the role of the patient and the patient's impact on revenue. In today's environment, you absolutely have to view the patient as a payer. We've seen an 83% increase in employee contributions to health plans over the last decade, which is a very significant increase. According to the American Medical Association, patient responsibility now makes up 25% of total revenue, with experts anticipating this to reach 50% over the next decade in all of healthcare. Patient responsibility specific to medical practices was nearly 30% of total revenue, and relative to ASCs, patient responsibility makes up roughly 10 to 15% of total revenue, only further supporting the patient's role as payer in our marketplace today. Just last year alone, the out-of-pocket expenses rose on average by 11%, and that is a trend that we do expect to continue. Understanding that the patient is one of the major sources of revenue in our space, we have to explore why this could be a challenge for healthcare providers. Not only is it important for providers to pay close attention to the trends in patient responsibility, but it is equally important for them to understand that collecting patient responsibility at time of service may be the best approach to maximizing revenue and improving the overall patient experience. This process will increase your cash flow while it's decreasing the administrative burden associated to back-end collection costs. In 2017, TransUnion reported that 68% of consumers were unable to pay their financial responsibility in full after services were provided, and they additionally expect the percentage of patients not paying their medical bills in full to rise to 95% by the year 2020. From just 2015 to 2016 alone, the number of consumers failing to pay full patient responsibility increased by 15%, a trend that is expected to continue. As a result, we're seeing a growing focus on collecting patient responsibility and appropriately estimating time of service costs for patients. Facilities and practices are also exploring where their inefficiencies and their wastes lie, and they're aggressively working to cut costs while maintaining quality and care. Already this year, we've watched the almost continuous barrage of headlines regarding healthcare technology, the expansion of telehealth, wearable health tracking devices, and cloud-based services, amongst others. Technology is incorporated in all areas of healthcare, and revenue cycle is no exception. Consumers want convenient access to healthcare and a streamlined process. As a result, providers are looking for ways to implement new technologies that promise to promote accuracy and efficiency while positively impacting the patient experience. Now, while we know that there will always be a human component to the revenue cycle, there are some areas where automation makes a big difference. To help providers collect these higher patient responsibilities, many practices are implementing automated tools that can help to evaluate patient benefits and eligibility and produce accurate time of service quotes. Having this information available will help better prepare front office staff and set proper expectations for the consumer. There are numerous benefits to the patient experience when you've implemented an automated tool focused on accurately calculating and collecting patient responsibility. This type of technology implementation helps to streamline the time of service collections process while ensuring that patients arrive prepared and in understanding of their responsibilities. These estimates also offer the providers and the office staff the supportive and accurate information that they need in order to discuss personal and customized financial responsibility with their patients, fostering a positive relationship between the provider and the consumer. Automation of this type can also help to reduce patient phone calls and decrease administrative burden associated to collections. Often, these technologies are integrated with the practice management system, or EHR, which eliminates inefficiencies and helps to reduce demographic and insurance capture error, which is a common cause for claim rejection or denial. When a claim is rejected due to error or denied due to documentation, it is the provider who suffers, as this creates a delay in claim adjudication and subsequent payment. I'll discuss more on denials management further in this presentation as well. Because patients really are a major payer in our space, holding a significant presence in the marketplace that is only continuing to grow, it's important for providers to understand that the revenue cycle has a direct impact on the patient's overall experience. A positive or negative experience related to the cost of care received and subsequent medical billing has an impact on the patient's perception of the care that they receive. Now, why is that? Well, the billing process is often the first interaction the patient has with the facility, and it's often the last. According to research from Fierce Healthcare, patient satisfaction ratings fall by an average of more than 30% from post-discharge through the billing process. In the event there are significant issues with the post-care billing, one would expect the satisfaction ratings to fall even further. Therefore, great attention needs to be paid to when and how you are collecting patient responsibility. Being thorough in your collection process at time of service will allow patients to focus solely on their recovery after care without continued financial burden. You can look at it in a different way as well. If you explain all financial responsibility and provide an accurate quote to patients at time of service, and they still decide to move forward with services, that's a strong indicator that they are in understanding of their role and that they're comfortable with their financial responsibility. What are some best practices that can help you maximize capture of patient responsibility revenue at time of service? First and foremost, do you have a sound financial policy relative to collections and patient responsibility? And if so, has it been provided to your patient or is it publicly available? It's recommended that you provide this policy to the patient as early as possible, preferably before they arrive at your facility. You can also post this policy publicly on your website if you have one, or you can post it in waiting areas and office spaces as well. The earlier that you set clear expectations relative to payment with patients, the better. You want to try to avoid surprises wherever possible here. Additionally, do you have a financial hardship policy or a financial and a medical indigency policy? These policies should follow the federal poverty guidelines and other guidelines which are publicly available to you. However, it will be important to review your state regulations as well for any additional considerations when determining charity care. These policies must also be applied consistently to patients. You do run the risk of fraudulent behavior when you only offer this type of policy to some, but not all patients who may qualify. And I'll also touch on items relative to fraud risk behaviors later in this presentation as well. Other ways to improve patient collections are to offer payment plans and financing options. These are great resources and services to have available to your patients. Not only do these options make the process of receiving care more efficient and seamless for the consumer, but they also decrease the amount of time and resources needed to follow back-end collections. Payment plan and financing options also allow the practice to engage the patient in their financial planning, and it supports a collaborative effort to find a payment plan that is manageable for the patient while meeting the provider's requirements. Maintaining a credit card on file as part of your payment plan can help to ensure that you're able to charge payments in a timely manner. Now that we've looked at time of service collections and ways to improve your upfront collections, we also have to explore back-end or post-care collections and some consumer protections that make this increasingly difficult. Now, I know that I mentioned these statistics relative to the supporting of time of service collections, but let me reiterate these points to ensure that you understand why patient responsibility and early collection is so important, and rather, why back-end collections are extremely difficult today. 68% of consumers admit to not paying their full responsibility after services are provided. This trend is growing and is expected to hit 95% in just a few years. Now, because we already know that 10 to 15% of ASC revenue comes specifically from patient responsibility, you can see the gravity of this situation. Imagine only being able to recoup 5% of that revenue instead. I don't know that many of us would be able to stay in operations for very long if that does become the case. So we do have to maintain a focus on collecting patient responsibility and collecting patient responsibility at time of service. So what are some things that you need to be on the lookout for? States are continuing their focus on consumer protection through the implementation or the expansion of balance billing and surprise billing legislation. These laws are the result of the ever-increasing presence of high-deductible health plans post-Affordable Care Act implementation. As a result, a patient may find that they have large and unexpected medical bills after treatment at an in-network facility by an out-of-network provider. States have long been making changes to legislation to protect consumers in these scenarios, which are often difficult to anticipate. From 2016 to 2017, at least 89 bills have been introduced in 28 states on the issue, with nearly every state in the country addressing some form of consumer protection related to balance or surprise billing. Understanding how your state regulates balance billing will help your facility remain compliant as you manage your revenue cycle. The National Conference of State Legislature is a great resource to review the individual states and their applicable state actions relative to transparency and disclosure of healthcare costs and provider payments. Here I'll share some examples of what's happening across the country. In Oregon, for instance, under this legislation, healthcare providers are prohibited from charging patients out-of-network rates for care provided at in-network facilities. Patients who receive care at in-network facilities will only receive bills at in-network rates, while the insurance companies and healthcare providers work out the remainder of the reimbursement. Over to the East Coast, and very similarly, New York State includes the following language in their financial services law, ensuring that patients are generally charged their in-network co-payment or deductible for out-of-network services, with an independent dispute resolution process set up for the providers and the health plans. Here I have a few examples that show the expansion of these consumer protections. This map is an example of states with partial or comprehensive protections against balance billing in January of 2017 for emergency departments. However, most of these pieces of legislation also include most scenarios where care is received at in-network facilities by out-of-network providers, including the ambulatory surgery center. Jump ahead to December of 2017, and in just 1 year's time, we see at least 10 additional states, seen on this graphic in red, that began pursuing or implemented balance billing restrictions. And as mentioned, at this point, almost every state in the country has some form of consumer protection against balance billing. Now, of course, we know that even if you get everything right on the front end with proper capture of patient demographic and insurance information, and even if we're collecting as much patient responsibility at time of service as possible, there's still an opportunity to leave money on the table if you're not properly managing your denials. The world of appeals today is very complicated. Not only do the individual payers define their terms for appeals, how many attempts you have, how often you can appeal, in what form you have to appeal, but also the individual states can also dictate timeframes and appeal limitations. I'll use Arizona as a quick example. In Arizona, you have a 2-year statute of limitation to appeal on claims, unless you are dealing with a federal plan or a plan governed by ERISA. In that case, the individual plan will dictate what your appeal limitations are, and they can vary greatly. As a result, it will be very important to identify what type of plan you're appealing, whether or not it's self-funded or fully insured. Self-funded plans, or plans where the employer is the one responsible for payment on a claim, not the insurance carrier, are governed by ERISA, the Employee Retirement Income Security Act. Sometimes these patients will show up at your office with an insurance card that looks like a normal insurance card from one of the major carriers. But in reality, the insurance carrier is simply acting in an administrative services only capacity. Claims are actually paid by the employer or the employer group. With self-funded plans, employers are required to provide their plan participants with a summary plan description or an SPD. This document will tell you exactly how claims should be paid and how you appeal your denials. Once you have a summary plan description, you can construct your appeal letter. The important point to remember here is that you have an opportunity to appeal directly to the employer or the employer group instead of the insurance company. Because it's the employer who's actually responsible for payment on a claim, appealing to the insurance carrier could prove unsuccessful and will more than likely result in a waste of facility resources. Using ERISA language in an appeal can help to expand your rights to appeal and to proper reimbursement as well. So I encourage you to make sure that you properly understand ERISA as well and identify whether or not you have self-funded plans in your patient mix to ensure that you're appealing correctly and not wasting efforts. With fully insured plans, you want to be sure to review the plan documents to understand what should be covered and what benefits exist to the patient. There are components of ERISA as well that do apply to fully insured plans. Your appeals can include language from contracts, fee schedules, and state laws. We've found that having significant supportive language to defend your stance, whether it's state laws, federal law, even reference to court rulings and judgments, helps to strengthen your appeal. If you're able to obtain a certificate of coverage or an estimation of benefits from the plan without exhausting an appeal effort, you can also use language from that document to support your appeal. As previously mentioned, be sure to know your appeal limits with both self-funded and fully insured plans. If a payer defines an appeal as a phone call, don't use that phone call to ask for an SPD or a reconsideration. If you only have one attempt, it should be as formal and robust as possible. Likewise, don't get too caught up in writing a novel that you lose your audience halfway down the page. Appeals should be professional, concise, and to the point with strong supportive arguments. Now, while you're meeting the challenges associated to collecting patient financial responsibility at time of service, you must also remain knowledgeable about your state regulations on medical debt collections. In the event that you're unable to collect full patient responsibility at time of service, be sure to review your state's statute of limitation on medical debt collection to ensure that you're compliant with collection practices and timeframes. While most states follow the federal Fair Debt Collection Practices Act, which dictates how a healthcare provider or a creditor may attempt to collect on debts, it is the individual states that may dictate specific timeframes during which you have the right to attempt to collect debt from a consumer. These limitations do vary significantly across all states and may also include qualifying criteria. Therefore, it is important to understand what your back office collection practices may include. So what are some of the best practices to help you with back-end collections? You must make an attempt to collect. An attempt to collect typically includes 3 patient statements and perhaps a phone call before you can either write off a debt or turn the account over to collections. Now, whether or not your facility's policy is to send patients to collections or not is completely up to you. It's not required, though it may be recommended in an effort to recoup all amounts owed to you. Additionally, if you plan to write off debt after an attempt to collect, this should be written off as bad debt so that you retain an opportunity to collect from the patient in the future. Anytime the patient makes a payment on the account in the future, this amount should be applied to their outstanding balance. Likewise, you should make every effort to collect all debt from a previous service before treating the patient for a new service. Many facilities include, as part of their financial policy, a clause that requires that patients satisfy their previous balance prior to new treatment. Now, I have received a great deal of inquiries about patient discounts, so I do want to touch on this briefly as well, as it does fall under back-end collection practices. Sometimes providers don't want to deal with the hassle of attempting to collect, and they do prefer to offer a discount as an incentive to get patients to pay their financial responsibility. Now, while there are some exceptions, like financial hardship policies and one-off situations, perhaps a facility error where you may be able to do this, you should not be consistently offering discounts to patients. And why is that? Well, the act of not collecting full patient responsibility can be viewed as fraudulent because you have a contractual obligation to collect patient copayments and deductibles. Not doing so, but still collecting the full allowable from the insurance company is viewed as a misstatement of your actual charges. Just this past summer, 3 Texas-based ASCs and a major carrier had to settle an ERISA violation suit. The facilities consistently waived patient payments for out-of-network bills, but continued to bill the insurance company. Likewise, the insurance company was on the hook because their plan interpretation was legally incorrect and it could not be enforced under ERISA. The facilities inappropriately collected nearly $8 million from the insurance company, and as a result, were fined. In the event that you do offer a discount to a patient in these one-off situations, you would have to offer the same discount to the insurance carrier or the payer as well. This adds an additional burden to the facility, and it supports avoiding discounts in general. I recommend that discounts always be reviewed by your compliance team or your legal counsel to ensure that there are no anti-kickback or Stark violations for incentivization as well. And this does apply to both in-network and out-of-network providers, because in either scenario, there are contractual terms that dictate the patient's responsibility and the provider's role in collecting it. There are many things to be aware of relative to patient responsibility and your role in collecting it. Be sure to frequently check your state laws, contracts with payers, and monitor federal regulation rollout. In our environment today, it is increasingly important to leverage technology, understand your governing regulations, and create process that supports a positive revenue stream to your facility. I thank you so much for your time today.
Kylie, thank you so much for your presentation. Always very informative and I hope helpful and great for our audience. We've got a number of audience questions to start with. Let me start with those, and then we'll keep on going for as long as we can keep you on the phone. So thank you. You had mentioned the potential expansion of the MIPS and APM program. When will we know what the status of this is going to be and whether those proposals will go forward, and what should people be thinking about?
CMS released its proposal to include more provider types in the eligible clinician category for MIPS and APM in its release of the Medicare Physician Fee Schedule proposal this summer. Shortly after, CMS released the Outpatient Prospective Payment System proposal, which impacts reimbursement rates in HOPDs and ASCs. It's expected that both of these proposals should be finalized around the first week of November, barring a potential government shutdown, and many of the proposed changes would take effect by January 1st of 2019.
And what kind of effect will those have on providers? Just a very quick sense of the effect that will have.
Well, it may expand the reach to eligible providers who have to participate in the MIPS and APM models. And as a result, the administrators in the ASC space may find themselves in a position to further support those eligible clinicians. The outpatient prospective payment system may have an impact on the rates for services provided, which can have a direct impact to your ASC's revenue.
Thank you. You had talked about getting the summary plan descriptions of self-funded plans. How do you do that, and what if you can't obtain that?
One of the most important documents participants are entitled to receive automatically when becoming a participant of an ERISA-covered health benefit plan is the summary plan description, or the SPD. The summary plan description is an important document that tells participants what the plan provides and how it operates. It provides information on when an employee can begin to participate in the plan, how services and benefits are calculated, when benefits become vested, when and if and in what form benefits are paid, and how to file a claim for benefits. The plan administrator is legally obligated to provide the SPD to plan participants free of charge. If a plan is changed, participants must be informed either through a revised summary plan description or in a separate document called a summary of material modifications, which also must be given to participants free of charge. You want to be sure to have an assignment of benefits form completed upon registration by your patient, which allows you to act on behalf of the plan participant and to interact with the insurance provider on their behalf. Additionally, be sure to include language in your SPD request that reminds the employer that as a fiduciary of the plan, you have a legal right to receive the SPD. Be sure to keep a record of all communications requesting the SPD as well, but if you can engage the patient in completing an assignment of benefits, that will help you greatly.
Thank you. One of the things you've talked about is the growing amount of collecting from patients at the time of service. How do you work with your front office staff and your office staff to improve upon this, to work with getting patients to pay their responsible share?
Well, the training of your front office staff is going to be absolutely essential. Ensuring that your staff is fully aware of and able to explain your facility financial policies to patients will be critical. You want to ensure that your patients are properly educated about their role and that your team can speak about the process of paying for their services with knowledge. Now, I previously mentioned the use of automated technologies that can assist your facility with running patient eligibility and quoting patient responsibility. And oftentimes, these technologies also offer resources that will support your staff's conversations with patients about their financial responsibility. These tools can act as a great resource for your team.
And what about, you had talked about being mindful of offering discounts to patients, account write-offs. Can you again review why this is important vis-a-vis responsibilities with payers and how your rates are set and so forth? A little bit more on that subject.
Yeah, absolutely. And this is something that in my role as compliance officer I deal with pretty frequently. The federal government is very harshly cracking down on fraud and abuse in the healthcare space. The routine waiver of co-payments and deductibles, as well as offering discounts or professional courtesies, has been labeled as risk areas by the Office of Inspector General. Now, the OIG encourages providers to make a good faith effort to collect co-payments, deductibles, and non-covered services from federally and privately insured patients. Billing insurance only may violate the False Claims Act, the Anti-Kickback Statute, the Civil Monetary Penalties Law, and some state laws as well. Likewise, the OIG's best practice is to stay away from providing discounts in any form of professional courtesy because it will violate contractual obligations with payers, and it can result in a misstatement of costs, with providers receiving full payment from payers but not collecting the patient's responsibility. This is one of the major reasons, in conjunction with the others that were discussed today, that it's so important to collect patient responsibility, preferably at time of service, because we know that it's increasingly difficult to get patients to pay for services after care is provided.
And let me ask you a different question. And again, it goes to this subject, and it's another question that just came in. How much out of network are you seeing, and how do you sort of deal with out of network versus, in collecting on it and setting rates and those kinds of things?
Well, we're seeing that the out-of-network space is beginning to shrink. Collecting on out-of-network will require you to review your state regulations. If you recall, I mentioned the balance billing and surprise billing legislation, and that's relative to services being provided at in-network facilities by out-of-network providers. And in many states, you will not be able to recoup payment for the out-of-network service. So it would be very important to review your state regulations to ensure that you're compliant.
Got it. And any special sort of advice for front office staff and scheduling staff on dealing with out-of-network or anything you do specially there? And in terms of training, and are you seeing a lot of out-of-network?
So again, the out-of-network space is beginning to shrink a bit across the country. I think it's important for the front office staff in a non-discriminatory manner to collect as much patient responsibility at time of service as possible, because we know how difficult it is to recoup payment from the patient after the services are received. We continually promote that the revenue cycle begins at the front office. And so it's very important to ensure that your team understands your financial facility policies, that they understand how to properly capture insurance information, and ensure that they have the ability to educate the patients that come to the facility about what their financial responsibility may be.
Kylie, I want to thank you. The information that you and National Medical Billing Services, NMBS, provides is just always great. The company itself has had magnificent growth and success in the ASC sector, particularly, but in other sectors as well over the last decade or so. Just a great growth story. I heard recently how many centers and how big a company you've become, but still providing very, very essential and great hands-on service. So we're very thankful for the effort that you provide here. This kind of webinar, completely informational, no sales effort, and just very educational. So Kylie, we're greatly appreciative of yourself, Lisa, Nader, and the entire company providing this information to our audience. So thank you so much. We look forward to visiting with you again shortly. Thank you.
Thank you, Scott.
Well,